McVey. I'm a surgical resident at the Austin Hospital in Melbourne, Australia. And today I'd like to present my research with Mr. Garson Chan and Mr. Gani on the utility of videourodynamics, imaging and cystoscopy in avoiding dysfunction and recurrent urinary tract infections. We don't have any affiliations to disclose. This is a self-funded research project. First of all, just some background. Of course, we all know recurrent urinary tract infections is a very common outpatient problem, a presenting complaint in patients. And with that, it comes with a significant functional burden for our patients, as well as financial burden for our health institutions. The management approaches to recurrent UTIs are varied, as are the guideline recommendations. And there's also sort of limited evidence and studies supporting some of the management practices that clinicians opt for. And a particular area that we've seen a gap in evidence was the utility of videourodynamics in this patient group. Therefore, the aims of our study today were to answer two questions. The first was, in patients with recurrent UTIs, what is the utility of videourodynamics? And secondly, is there any role for additional imaging, fluoroscopy or cystoscopy? Our study was a retrospective cohort study. It included 1,031 patients initially referred for physician-performed urodynamics from 2013 to 2019 in our centre in Australia. And we applied inclusion and exclusion criteria, as you can see detailed on my slide. In particular, the inclusion criteria was recurrent UTIs, which we defined as more than 3 episodes per year or more than 2 episodes in 6 months. And there were 132 patients who met the inclusion criteria who went on to have further data collected and analysed. And of course, we sought institutional ethics approval. So just a rundown of the demographic of our results. And the median age was 62 years, and the vast majority of our patients were female at 87%, and recurrent UTIs was the primary indication for urodynamics in 55%, and the rest of that group being made up by it being part of their presenting complaints, but not necessarily the primary indication. It was interesting to find that an identifiable cause was diagnosed on urodynamics in 67% of our patients, and a few of the examples of what we defined as an identifiable cause are included. As you can see, for example, outlet obstructions, Fowler syndrome, detrusor underactivity, and we did note gender was not predictive in finding an identifiable cause. Something that stood out in our results was the association between voiding symptoms and the likelihood of an identifiable cause on videourodynamics, and that was whenever we compared our group of patients that did not report any voiding symptoms. So as you can see detailed in my diagram on this slide, 67% of patients with voiding symptoms, they made up our total group, and 33% did not have any. And it was actually 77% with voiding symptoms had an identifiable cause compared to 45% who did not have voiding symptoms, and this was found to be statistically significant on p-value. Further results we found were cystoscopic abnormalities were seen in 20%, but mostly of no significance or low significance, so things like cystitis, cystica, and inflammation. 14% of patients had fluoro abnormalities, and of the patients that had additional imaging available, particularly those that were being investigated primarily for UTI, none of these had none of the imaging that they had was diagnostic for a cause, and thankfully there was no malignant findings of imaging or cystoscopy. So how we interpreted these results were, first of all, we were able to sort of summarise and say that urodynamics are potentially an important investigative step to diagnose an underlying cause for recurrent UTIs, and in particular this is in the group of patients with voiding symptoms, given we found that a high proportion of these were found to have a treatable diagnosis. Of course, like anything in medicine, if we have the correct diagnoses from the get-go, we're able to direct more specific treatment and manage these patients more specifically and hopefully in the long run better. and save them years of potential misdiagnoses or inappropriate treatment. And really, we did have sort of suggested that additional imaging or cystoscopy is not necessarily helpful in diagnosing the causes of recurrent UTIs. But of course, it may be important in other indications, depending on the presenting complaint, to rule out things like malignancy. Our limitations were that our study design is of course retrospective and it was a small study size, and there was variation in the medical documentation, and that is what we relied on for our results. And also there's always a potential for confounding factors for things that we haven't considered. But overall, we were able to conclude, and in answer to the original questions that we posed, we would summarise by saying that urodynamics, video urodynamics is useful diagnostic tools in patients with recurrent UTIs, and many of these patients do have an identifiable and treatable cause, but we would say that additional imaging, fluoro, cystoscopy is unlikely to be of individual benefit, but of course this does warrant further investigation. Thank you very much, and I would love to welcome any questions that you have.